Alan Critchley, an independent social worker, and I'm going to talk to you about Carissa, Safeguarding Adult Review. She was 66 when she died in October 2022. She had lived in Kent with her husband, who was some 20 years older than her, and a daughter. The couple had been together for 47 years. Carissa had been alcohol dependent, or at least a heavy drinker, for some 10 years prior to her death, and she smoked. She'd had a stroke in 2013 and was known to have suffered from anxiety, depression, and some physical health issues that may have been related to excessive alcohol consumption. Over the timeline of the review, which was from August 2021 until her death in October 2022, Carissa was cared for by her husband and her daughter. Her husband bought alcohol for her, and while he may have wished to buy less or none, he described her mood as being difficult if he didn't do as she wished. In March 2021, Carissa was taken to hospital with bruising all over and having breathing problems. The bruising was unexplained. In August 2021, Carissa's husband contacted the GP saying that Carissa was suffering from low mood and had expressed suicidal ideation. She'd been offered, but had rejected, alcohol support referrals. The doctor believed that she had the capacity to do this, although capacity wasn't formally assessed. Carissa said that she believed her life was over. She was only eating crisps and she was sleeping from 4 a.m. to 4 p.m. Over the next few months, there was some good work from agencies to attempt to engage with Carissa and to support her husband. In respect of him, a carers assessment was completed and he was offered support. Referrals were also made to Kent Fire and Rescue Service in respect of Carissa's smoking and the danger that lit cigarettes posed. A nutritionist worked with her and tried hard to find tools and supplements that she would like. Carissa didn't leave the house, but selectively saw professionals when they visited her. Knowing that she was only awake from 4 p.m. onwards, most contacts were helpfully accommodated during this period. By early 2022, Carissa was described as visibly deteriorating. Support continued from the agencies, and Carissa was considered at an MDT, multidisciplinary meeting, that is. There was little that could be offered beyond the support currently given, because Carissa was clear that she had no wish to cease smoking and drinking. She continued to deteriorate, and in August 2022, Carissa's husband reported that she'd asked him to help her die. She was described as being weak and fragile, and she was refusing help. The risk from the MDT was assessed as red due to her suicidal ideation. Although this lessened in subsequent weeks, there was no sign that Carissa wanted to receive any help to get better. In October 2022, she was weak and depressed and refused to go to hospital. Paramedics undertook a capacity assessment and a best interest decision was made, and she was taken to hospital where she died 2 days later from multi-organ failure, sepsis and frailty. Over the timeline, Carissa said on several occasions that she wished to die. She also made it clear that she wouldn't give up smoking or drinking. This was really hard for the family, but there was little that they or others could do. People who are alcohol dependent may have capacity to make some decisions, especially during periods of sobriety. But an assessment should always be made of their executive function, sometimes known as their ability to walk the walk rather than talk the talk. If she had capacity, she would be able to make an unwise decision without anyone challenging her. What wasn't recorded was whether Carissa went through the process of weighing up the pros and cons of managing her dependency, and it was therefore not safe to rely on the assumption that she knowingly made an unwise decision. Given clear evidence that Carissa wasn't keeping herself safe, the self-neglect protocols should have been followed. The multi-agency input to work with Carissa was impressive, but overall coordination could have been improved through the MDT. Carissa's physical and mental health were inevitably linked. She'd suffered ill health for many years, having had a stroke or series of mini strokes in 2013. She'd been a heavy drinker and smoker for many years, or at least since her stroke. She'd complained of lower back and abdominal pain, and she spent the majority of time in bed. The combination of probable muscle weakness and alcohol meant that she was unsteady on her feet and she suffered from frequent falls, causing bruising. Whilst there was an inevitable link between Carissa's physical and mental ill health, it was difficult for this to be explored because she kept agencies at arm's length and engaged only where help was of a practical nature. From the information given to this review, there is no evidence that any one particular person attempted to build a close relationship with Carissa. Shoot and Ward in 2020 talk about assertive relationship building, harm reduction, and motivational interventions. Building up trust with one particular worker may have allowed Carissa to be more open with her thoughts and feelings, and in turn, she may have listened to the worker. Now, this is said with hindsight and in the knowledge that Carissa may not have been receptive to such attempts at relationship building. There was good use of the blue light manual, which includes which include attempts at harm reduction. The use of the MDT was good to assist and coordinate the resources going into the house. It pooled and combined multi-agency resources. As this review has shown, there was probably little that could really have helped Carissa, as she was clear that she didn't want to change her pattern of drinking. The GP's referral to the multidisciplinary team for review was good practice. The clinical nutrition and dietetics team demonstrated good practice by trying to find different foods that Carissa would be happy with. So, now my recommendations. The MDT, the multidisciplinary team, and their coordinated approach is commended. They should ensure, through its coordination, that a stepped approach is used to ensure that outcomes for those considered are planned, strategic, and proportionate. So, a stepped approach, always looking for the next step if one step doesn't work. Now, my next recommendation. Carissa had expressed a wish to die and wasn't accepting help or care that might lead them or anyone away from that. In such circumstances, advanced care planning should be discussed with the person and their loved ones and carers. Relevant agencies, health and social care, should meet to consider how such conversations are held, where they are held, by whom, and what securities need to be in place before the conversations happen. My recommendation 3 is that whilst it's recognised that Carissa's husband was offered carers support, there should have been more of a think family approach, so involving the whole family, Carissa's husband, daughter, and Carissa herself in terms of the assessment. Those are my recommendations, and I would suggest that you read both the learning review and, if you have time, the full review if you'd like more information. Many thanks for listening, and thank you for hearing about Carissa.